So I'm a clinical senior lecturer in public health medicine at Imperial College London. I'm an honorary consultant in public health. I'm director of postgraduate taught programmes in the School of Public Health at Imperial. I'm team lead for innovation and evaluation within the North West London Applied Research Collaborative. And along with Liz Dominique, who's on the call, I'm going to see Liz today at the National Association of Primary Care. I support the NAPC in terms of the national rollout of the initiative, this Community Health Wellbeing Worker initiative. I principally support the expansion also in Westminster and in North West London, because that's the locality where I'm sort of predominantly based. But before becoming a consultant in public health medicine, as Don said, I was a GP in Brazil for several years, for 4 years. I actually am a Brazilian GP, even though I was born bred in England and trained in medicine in England. I emigrated to Brazil soon after medical school and requalified in medicine there, learned the language, took exams, which was horrible, but I gave me the opportunity to work in a single-handed GP practice within what's called the Family Health Strategy, which is their primary care system. And I was working in a single-handed practice in northeast Brazil, a little town called Camaragibe, hugely impoverished. I had 5,000 registered patients on my list, which is about 3 times as many, more or less, as we have per GP, full-time GP here in the UK. And the context where I was working was incredibly impoverished. So we had no sanitation, very precarious electricity supply, huge amounts of literacy, gang violence. We had some awful diseases as well that we don't really see here in the UK. I had daily hemorrhagic fever cases, leprosy, really serious multi-drug resistant tuberculosis, leptospirosis, schistosomiasis, all sorts of really interesting tropical diseases. You'd think that for a single-handed GP practice, where I just had one nurse and one nurse auxiliary within my clinic, that I would be overrun with demand in that context. And it was a fascinating experience, really, because I really wasn't. I had to see, as a doctor in that context, I had to see people who had to see a doctor. I never saw anybody who didn't need to see a doctor. People who wanted to come in for a chat or a pre-prescription or just a bit of advice or anything like that. I never had to see that. I never had a queue outside my clinic, and I had 20 minutes per patient. And as a GP, I thought that was quite incredible in that sort of context. And I came to realise that the reason why I was able to work in that situation and to that level of effectiveness, where 90% of all the conditions that we saw in primary care were resolved in primary care, we only referred 10% of our patients to secondary care in that context. The reason why it was such an efficient clinic was because I had community health wellbeing workers. They're called community health agents. We use the word here in the terminology of community health and wellbeing workers in the UK, but basically the role is the same. There in Brazil, my community health workers, we essentially divided the geography that I was responsible for, which was a completely delineated geography of those 5,000 residents. There was no other clinic in the area. Everybody in that geography had to be registered to my clinic. That was divided into 4 sections, essentially of roughly equal size, corresponding to about 120 to 150 households each, in each geography, micro areas we called them. And we recruited community health workers from the local area. These were lay people. They weren't medically qualified or even clinically qualified in any way. They would have completed secondary school education, equivalent of A-levels. Maybe they would have a degree, but it wasn't necessary. But they just were problem solvers. They loved the community. They wanted to really help and support. And their mandate, and they were paid full time, was to visit every single household in each of their respective areas once a month. Simple as that, or more than that, if there was a need. And by visiting every household once a month, they would get to know their families, their residents really, really well, build those relationships, know who's okay, who isn't okay, if they've got any problems, if somebody's been discharged from hospital suddenly and they need to check in on them. They would know who was eligible for immunisations, who was pregnant, who was breastfeeding, who was suffering from depression, who was a bit off colour, who was lonely, they would know if one of the adolescents in their area was at risk of truancy or entering gang violence and gangs or taking drugs. They would just know everything in those little areas of 150 households. They would know everything and about everyone because they would build up that trust and those relationships over time with those residents. They were from the community essentially. But they were also health professionals because they were paid full-time workers within my team. So they didn't just have all that intelligence, local intelligence, and keep it to themselves. They were also members of my clinical team. So as soon as something arose in their community and they needed to speak to me about it, they would just come to me straight away and say, I'm worried about Mrs. Jones living at number 23, she seems a bit off colour. Could she come in and have a chat and figure out what's going on? Or we know that her blood pressure's really not under control at all. Or she says she's not smoking when we know that she is. All of that detailed intelligence would be able to come to me as the doctor in that community and would be able to firefight and troubleshoot and resolve all of the problems in those areas before they became proper problems. So it was a really important role, and it's because of the Community Health and Wellbeing Workers being deployed in that way. So in summary, 3 core features of this role. They're universal. They visit all the households in their small areas once a month, if not more frequently. They're integrated into the primary care team, and they're comprehensive. So they don't just focus on one particular clinical condition or age group. They look at the entire life course and anything that might happen within it, providing low technical support across all those areas. Because of those 3 features, my job as a doctor became exactly what it needed to be, which was to be a doctor. If I needed to go out into the community and visit someone at home, I would know so immediately because the community health workers were there straight away, telling me what I needed to do with the residents they were looking after. So it's a hugely important role. And I realised when I returned back to the UK in 2004, it is not a role that we actually have. I didn't have at that time. You know, we have health visitors and district nurses and more recently social prescribing and link workers and community champions. We have health trainers, we have peer support workers, we have care navigators, you name it. We have loads of roles, but we didn't have a single role that had the same attributes or characteristics that community health workers have in Brazil. That is to say, responsible for a small area, visiting every household in that area frequently, building up relationships. So there's no discharge in that context. It's longitudinal, relational, not transactional, integrated into statutory services such as primary care and beyond, paid full-time, lay community health workers, so from the community, so they know the community very well, and they can self-identify as being from that community, and covering a wide array of problems focused on one condition. All the roles I mentioned earlier that we have in the UK have elements of that. For example, visiting people in their homes, but only focusing on one condition or one age group, or being very proactive in the community, but not integrated into primary care, working in parallel through the VCS, for example. So we have in the UK a situation where this role just didn't exist. And for many, many years, I came up against, I think, quite a lot of prejudice, actually, around learning about this role. In part because it was from Brazil, and in part, which isn't a country we traditionally pay a lot of attention to here in the UK, but also in part because it's generally perceived that roles such as this sort of proactive community health worker role is something that's suitable for poor countries, not for rich countries. We seem to have gone down a bit of a route where we like to target people for the clinical conditions that they have and develop initiatives that focus on those conditions only. We might, for example, identify people in A&E who use services more than we think they ought to and develop initiatives to address those problems. But I think what the role in Brazil demonstrates, what the community health workers in Brazil demonstrates, is that by being proactive, by visiting people in their home, you really solve many problems that we experience downstream across the health ecosystem and the social health and social care ecosystem. Unnecessary attendance at A&E for any condition can be resolved by having community health workers visiting people in their home and identifying problems early on. Okay? Bed blocking in hospital can be resolved because community health workers can be the first people to visit someone at home once they're discharged. So community health workers can unblock lots of issues in our, I think, very overwhelmed health system, because whilst a low technical level solution, whilst relatively unqualified but not unskilled healthcare workers, these individuals can actually at scale unblock an awful lot of problems within the system. And we've seen it in Brazil. So for example, they now have 275,000 community health workers across the whole country. Okay, those community health workers serve around 75% of the entire population, each one visiting every household at least once a month. They're in 95% of all municipalities across Brazil. And in the areas where you have a high penetrance of these community health workers compared to areas that don't, over the last 20 years, the former areas have seen a drop in cardiovascular disease mortality by over 34%. So it's a really, really important public health system. It means that through community health workers, because they have that engagement, because they're visiting households in their small areas routinely and regularly, you can use them as an infrastructure to integrate any new or eventual public health priority that happens to emerge over time. Whether it's a measles campaign, immunisation campaign, or COVID vaccination, whatever it might be, you've got people knocking on doors, checking in and seeing how people are day to day. Then you can integrate any eventual public health policy into the work that they do over time. So what's happened, and I'll stop in about 5 minutes just to sum up, but what's happened since in the last 2 or 3 years has been really very exciting. Whilst it's taken many years to get to this point, and it's unfortunate that we didn't pay attention in the UK to the evidence from Brazil pre-COVID, because we could have had potentially an army, like they did, of community health and wellbeing workers across the whole country, supporting everybody in their households during pandemic times. We nevertheless have made some significant strides in recent years in trying to get this initiative off the ground. So it began in Westminster, in a very small, well, it's actually a very large council estate. It's one of the largest in Europe, a very deprived area in Pimlico called Churchill Gardens Estate. But we began with just 4 community health and wellbeing workers, serving, like I said, 150 households each. We allocated them to, if you can picture a big council estate in inner London, we allocated each community health and wellbeing worker to basically big housing blocks, within which there'd be 20, 30, 40, 50, even 70 different households. So each community health worker would have between 1 and 4 blocks that they would be responsible for. And their mandate was to, as they do in Brazil, knock on every single door as frequently as possible in order to, by the end of the month, at least attempted to reach the households, the residents within each of those homes. Just find out how they are. What are their problems? Are they eligible for immunisations but haven't had them yet? What might be the reasons? In a very, very short space of time, we think, only about a year, we actually noticed that the households that have been able to be visited, and I should say that it does take time for households to be visited. We're not used to people knocking on our door just yet and finding out how we are. And in that context, it took about a year for about 60 to 70% of the residents to receive a visit from the community health and wellbeing workers, but they persevered nevertheless. And in that time, the households that were visited, compared to the households that hadn't yet been visited by a community health worker, we saw some really interesting and important increase in the uptake of immunisation, screening and health checks by the residents that had been visited compared to those that hadn't. So for example, for those that were eligible for immunisations, there was an increase in 47% of uptake in households that had been visited. For screening, it was 82% increase in the likelihood of uptake of screening services, and almost a tripling of NHS health checks, just because of the visits by the community health workers. So important was this signal whilst not statistically significant, because there was only 4 community health workers over a very short period of time, this signal was really important. It wasn't surprising at all that community health workers were unearthing those individuals that were eligible for services but hadn't yet received them, and helping them to be signposted in to receive those preventative services. Not surprising, but it was very important to see and capture. And subsequent to that, we've actually working through the NAPC with Liz and Nav Chana and Caroline Taylor and many others, and through the hard work of Connie Nunans, who launched the pilot in Westminster, Jeff Blake, Saul Kaufman, we're now seeing pilots emerge not just in Cornwall, but also in Bridgewater, in Liverpool, in Calderdale, in Kensington and Chelsea, in Wandsworth, in Oxford. Really exciting developments. What's challenging, whilst the idea of a community health wellbeing worker is simple, what's challenging is the implementation. And we do see some variation in how it's being implemented in all of these different localities. Some of that variation is important to have so that you can tailor the role to your local context. But what's also really important is to maintain those 3 characteristics that I mentioned earlier. The universality, so that is every household being reached or attempted to be reached within a mandate for that community health and wellbeing worker across small geographies of 150 households or so. The comprehensiveness, not just focusing on 1 or 2 clinical conditions or age groups, but looking at the whole household in the round, and the integration of that individual into the statutory services, primary care principally, but also social care and local authorities, so that those community health workers can be effective in referring individuals that need more support into those services. So those are the 3 features that need to be retained. Other features that we consider to be more peripheral, whether or not the community health workers do or don't measure blood pressure in the home, whether or not they do or don't get particular training in breastfeeding support, those are peripheral elements to the role. The 3 core features are universality, comprehensiveness and integration. Without all of those 3, we're just doing what we're already doing. So we're very excited, I have to say, within NAPC and also in Westminster and other areas, that this is starting to gain traction. Delighted to see this happening in Cornwall, and I'm very, very keen to hear how things are going in your experience there. In the latest news, in Westminster, they've just recruited a further 24 community health workers to serve North and South Westminster, with a view to actually increasing that over the next year or 2 to over 100 community health and wellbeing workers. And working with us at Imperial College as evaluation partners, we're now submitting to do a cluster randomised controlled study within that context, so that we can develop the necessary evidence base for the impact of community health workers, so that we can support its scaling.